Welcome to our online training. Today is June 25th, 2025. It's 7:02. For Tanzanian, it's 1400 in saa nane mchana. We are training today on neonatal sepsis, and we have our great three facilitators, Dr. Henry Akimbi, Dr. Annie White, and Dr. Lilian Msambi-Chaka. I'm going to let them introduce themselves as they start. Quick notes, when you come in, please sign in on the chat. Just put your name and your name of the hospital and the country you're from so we can interact with you and make sure we include in our discussion where you're coming from. If you have any questions, please type it in there. Whether you type it in Swahili or English, that would be great. And then I can share with the facilitators as continue, or we can do at the end of the presentation. So I'm going to let them start because I can't wait anymore. So Dr. Msambi-Chaka, please introduce yourself. Thank you.
Thank you, Dr. Harriet. My name is Lilian Msambi-Chaka. I am an internal medicine and pediatric hospitalist at Christiana Care Hospital in Delaware. And I'm very happy to be here today to co-present on a topic that's very near and dear to my heart with my colleagues. And I'll let them introduce themselves. Dr. Kimby.
Hello, everybody. Good morning or afternoon, as the case may be. My name is Henry Akimbi. I'm a neonatologist. I've been at Cincinnati Children's Medical Center in Cincinnati, Ohio for about 31 years, 32 years. And again, you have a good lineup of presenters. I'm honored to be part of it, and welcome.
Dr. Annie White.
Yes, hello. Okay. Is this okay? Oh no.
Just mute the phone and then you can speak on the computer. Just mute the phone. We can't hear you.
Okay. Now?
Perfect. Thank you.
Yes. Okay. Technical difficulties this morning. Sorry about that. I am Dr. Ann White. I am a neonatologist. I trained under Dr. Akimbi at Cincinnati, and now I work at the University of Minnesota. So I'm so happy to be here with you all today.
Welcome. Thank you, Dr. Ann. Dr. Msambi-Chaka, go for it.
All right. Well, I guess we'll go ahead and start. I'll have to say that I did my medical school at the University of Minnesota, so we have that in common with with Dr. White.
Small world.
Small
Yeah.
world, small world.
All right, we'll go ahead and get started. We will try and cover. Let's see. Let me just make sure. These are the outline for today. We will just talk about the epidemiology of neonatal sepsis management. We'll talk about infection prevention and the cost-effective way of sterilizing instruments in low and middle income countries, especially as it pertains to like hospital-acquired infection. As we talk about this, feel free to ask questions as we're going for clarification. If you think your question can wait until the very end, that is fine as well, but we'll try and make this as interactive as possible. We have a lot of material to share with you guys today, so but the most important thing is your questions and clarifying information. So
I will lead off. Again, I don't have to tell this audience how important infection is, especially neonatal sepsis, is the third leading cause of mortality after prematurity and birth asphyxia. So easily, this is a very, very relatively conservative estimate that about 336,000 babies die from infection. This is this was from 2015. And I say this is a very, very conservative estimate because we know that a lot of deaths are not recorded or are not ascribed to infection as such. So it's a very, very important topic. everywhere, not just in the low and middle income countries, here as well in the United States. It's a very, very big issue. In spite of all the advancements in medical technology and everything else, so it still strikes a lot of fear in neonatologists all the time. So, next slide, please. So again, we'll do a couple of vignettes just to illustrate our point. I will start with a recent case I just had maybe a couple of weeks ago in one of the hospitals I practice in here in Cincinnati. So I had a baby that was delivered at 32-week gestation to a 30-year-old G3P3 mom. The delivery was occasioned because there was a concern for severe fetal growth restriction, and the mom's non-stress testing was concerning. So we was delivered by C-section, and because of all the concern about towards the end of the pregnancy, and especially we don't have a good reason for the fetal growth restriction, baby had blood cultures and blood counts and chest X-ray were all performed because baby had the oxygen requirement, but they were all normal. But still, because of that concern, the baby received empiric antibiotics for about 36 hours. And why 36 hours? We can go into that. Is because we have come to realize that with the current culture system, the current pathogen detection system, 36 hours is more than adequate for a culture that's going to turn positive to do so. So baby did fine, got surfactant because of respiratory distress syndrome. So got some surfactant. We call it LISA. That's when you don't truly intubate them. All you do is pass a catheter through their vocal cords and squirt some surfactant in. So that's a trend. That's a common practice. So the baby got surfactant in the first day, and the wife was on nasal CPAP and was returned to nasal CPAP part of the surfactant. But then the following day, by day 4, had increased oxygen requirement after he's been intubated for a second dose of surfactant. And that caused a lot of concern because now the baby was 4 days old. Typically, the normal course of RDS is that by the third day, usually they've gone over the hump and they start to do a lot better. So this baby was getting worse, required more oxygen, wasn't able to maintain his blood pressure. So that was very concerning for, again, infection and whatever else might be going on. So the baby was cultured a second time, and then was placed back on antibiotics. Now a slightly different regimen of antibiotics, and then behold, by 2 days later, not quite 2 days later, actually, by the following day, the blood culture grew E. coli, and that we could have predicted that because the blood count on the baby, on admission, had a Y count of 12,000. By this day of life 4, the Y count had dropped to 1,700. That's a big decrease in the Y count. So that was concerning for infection anyway. So the baby got placed on a broad spectrum antibiotics, but still the baby passed away by 2 days later by day of life 6. Next slide. So again, this is to make the point that while infection is relatively uncommon, neonatal sepsis, but it could progress very, very rapidly from the baby on the left side, looking perfectly healthy, very curious, and then wondering what was going on, to a baby on the right-hand side that just, decompensated very, very fast, right in front of your eyes, requiring oxygen, requiring oxygen support. So that's the nature of neonatal sepsis. Early onset sepsis, late onset sepsis, you name it. It's the progression could be extremely rapid. So, job this morning is to again say the obvious that infection is very important, and how you go about diagnosing and treating them are critical. But the thing to remember, if you're going to take anything away from this talk, is that time is the essence. While blood culture, blood counts, and all those things are important, but it's more important to initiate antibiotic therapy promptly. So again, we regard neonatal sepsis as bloodstream infection in babies that are less than 28 days old. And the gold standard, of course, is a positive blood culture. And it's, like I said, it's a leading cause of morbidity and mortality among infants in low and middle income countries, as well as advanced countries as well. So it's just a troubling issue anywhere you are. And the preterm neonates are at much higher risk. And the number one risk factor for infection for neonatal sepsis is prematurity. So preterm babies and babies that are low birth weight, this again, less than 1,000 grams is actually extremely low birth weight. They are the highest risk for infection. And again, even though we all preach that blood culture is the gold standard, but the sensitivity of blood culture is woeful because only 3 to 8% of your blood culture will turn out positive. And we know that no matter what you do, the technology is improving and we are able to detect a bloodstream infection more readily, but still, it's still less than 10% of your cultures are going to be negative in babies that you know are probably most likely infected. Next slide. So again, neonatal sepsis is classified as either early onset sepsis or late onset sepsis. And early onset sepsis, I'm sure you're very familiar with, is infection diagnosed in the first 7 days. For research purposes, sometimes we use 3 days and sometimes we use 5 days as the cutoff. But no matter what, it's always due to vertical transmission from the mother. So it's either mom had group B strep or some other infection, especially E. coli. Those are all notorious. Group B strep are notorious for early onset sepsis. Occasionally, we encounter coagulase negative staph, and very, very seldom we encounter listeria and serratia in early onset sepsis. And those are more troubling pathogens. But again, the main risk factor, and we'll go through these multiple slides, are chorioamnionitis, mom is colonized with ruby strep, but prematurity by far is the biggest risk factor. And if there's a history of prolonged rupture of membrane, actually more than 18 hours. So again, late onset sepsis is also sepsis diagnosed after the first 7 days. And typically it's horizontally transmitted. So it's either from healthcare providers, from the parents, from the environment, typically. So, and it's almost never a vertical transmission. So it's not typically acquired from the mom. And like I said, the risk factors again are prematurity, especially babies that are in the newborn intensive care, that stay in the newborn intensive care for that long. Other risk factors are babies that have intravascular catheters, umbilical, peripheral, PICC lines. Those catheters are a common source of infection. Even babies that are intubated, the endotracheal tube is a common source of infection as well. And like I said, GPS is still a big player in late onset sepsis. E. coli is a little bigger than GPS, than group B strep, but now you have a lot of coagulate negative staph as your staph epidermidis. Those are the leading causes. But like early onset sepsis, your blood culture may not be sensitive enough. In fact, blood culture is good for its negative predictive accuracy, not so much for its positive predictive accuracy. Next slide. And this is to reiterate everything we've said about the risk factors for neonatal sepsis. Again, early onset sepsis, we talked about prematurity, and you see prolonged rupture of membrane, especially if longer than 18 hours, chorioamnionitis. If mom spiked the temperature during labor of greater than 37.5 degrees, typically 38 degrees as a cutoff, and then mom had a history of bacteria, especially with GPS, that puts the babies at much higher risk for early onset sepsis. And the typical pathogens we encounter, we mentioned them already, are GBS, group B streptococcus, E. coli, We said occasional listeria, occasional serratia, Haemophilus occasionally, and the Klebsiella. For late onset sepsis, as we said, again, prematurity, that's the biggest risk factor. Prolonged hospitalization, especially in the newborn intensive care unit. And we talked about instrumentation, either with umbilical venous catheter or umbilical arterial catheter as well, endotracheal intubation, and babies that are on mechanical ventilation. So these are babies that are the highest risk for infection. Other disorders may play into it as well. Babies that have open wounds for meningomyelocele, for instance, tracheoesophageal fistula, babies with intracranial hemorrhage. And the common pathogens encountered in late onset sepsis are, again, we mentioned the group B strep is still a big player. E. coli is a big player as well. Now you start to have Staph aureus, Haemophilus, influenza, Klebsiella, and then Pseudomonas. And I just listed for clarity the risk factors for late onset sepsis versus the major risk factors and minor risk factors. So anytime you have rupture of membrane for longer than 24 hours, that's a big risk factor. Temperature, especially when it's above 38 degrees Celsius. Choreo, we mentioned several times. And when babies or the fetus has sustained heart rate of more than 160 per minute, that's a concerning risk factor. And again, multiple obstetric procedures could put a baby at risk for infection. And the minor risk factors are, again, rupture of membrane more than 12 hours, and then if the amniotic fluid is foul smelling, that's concerning for possible infection or put the baby at risk for infection. Maternal fever, again, more than 37.5. Low Apgar scores as well. Those are associations, of course, but and then prematurity, as you mentioned, and then multiple gestation becomes a risk factor as well, for a minor risk factor. Next slide. So again, the way I conceptualize a neonatal sepsis is one, there are babies that clearly, clinically appear septic, poor perfusion, on inordinate oxygen requirement, very difficult transition. Those babies, again, we will still do the workup, the blood counts and blood culture and stuff. But again, even if their culture is negative, nobody will controvert you. You should start those babies on antibiotics and keep them on antibiotics. And then there are babies that, have might qualify for some of the risk factors, but they are not that sick, or they had all some of the risk factors we mentioned prenatally, but they come out, they look very good, and they don't require any oxygen, they don't require any resuscitation hardly. So those are babies that you probably could wait and observe clinically without any intervention. The work of the blood counts and blood culture, you could hold off on those and observe them. And there are some babies that are in the middle that have lots and lots of risk factors, lots of them, and they are mildly sick. They are not very sick, and you have to decide: it is a atypical transition? Is this having difficulty with transitioning to extrauterine life, or is it a sign of infection? And that's where some tools might help you decide how much intervention or how much investigation to do, how much even if you're going to delve into antibiotic therapy. So I have this QR code, and this is one of several tools that are available to you that it's called the Neonatal Sepsis Calculator. And so if you just, can you go to the next slide, Lillian? So if you click on that, and then it will take you to this page where you can put in the baby's gestational age, how old the baby is the baby or the baby's temperature. If mom was colonized, for instance, with group B strep, which is not the usual practice in Tanzania. I understand that mothers don't get screened for group B strep necessarily. So you put in all these factors in there, and then once you enter all the clinical variables, then you click calculate, and it will tell you the likelihood of infection and how much investigation to do. So there are babies that you highlight red. That means you do everything. There's clearly enough evidence to show that that baby is most likely going to be infected. And it might, on the other hand, it might just be completely green to show that the likelihood of infection is very low. That's a baby you can just you can afford to observe. And then there will be babies in the middle, in the gray zone, that you have to factor in your own clinical decision to say that, yes, this is how much you are going to do. And so that's going to rely more on your clinical discretion, so to say. Next slide. So again, major causes of neonatal sepsis, we've gone through a number of these already. Group B strep, Group B strep, Group B strep in early onset sepsis is a very, very big player. E. coli, we mentioned the occasional strep viridans, that's a Group A strep. Enterococcus, Staphylococcus aureus, Group A strep, Haemophilus species. And again, we have to remember listeria is one that strikes fear in everybody. Listeria, and occasionally we encounter serratia. And for late onset sepsis, commonly we see coagulase negative staph. Group B strep and E. coli are C players, and then you have to you encounter enterococcus species as well as Pseudomonas. So next slide. And these are the common clinical presentations. Baby may have fever. And on the other hand, actually, what strikes more fear in me is a baby that is unable to maintain his temperature or her temperature. So if you have a baby that have low temperature, for instance, I'm more worried about infection than a baby that has a fever. So hypothermia is a big, to me, it's a bigger concern than fever, actually. So again, a baby that has apnea or in respiratory distress, babies that are not very preterm babies go through that kind of phase, but term babies that have apnea is probably sepsis until you can prove otherwise. Again, tachypnea, lethargy, poor feeding, again, apparent change in the mental status, as poor perfusion and decreased tone. So those are all signs that should be concerning for infection. Unfortunately, there's a lot of overlap with signs of difficult transition to extraterrestrial life. So that's where your clinical judgment, your how much concern to have will be based on your bedside assessment, and probably better to err on the side of caution for the most part, because like I said, the progression of sepsis could be very rapid. And having babies on antibiotics maybe for 36, 48 hours, probably it's not the end of the world. It's probably better than to allow things to drag and the baby progresses rapidly right in front of you and decompensates. Next slide, please. And again, we went through most of these, the clinical findings in neonatal sepsis. Again, it could be respiratory with a lot of distress, requirement for oxygen, supplemental oxygen. Could be tachycardia and hypotension, delayed peripheral perfusion, for instance. And the GI symptoms, as well as neurological and renal, and the hematologic and dermatologic factors, which again are things that will make you be concerned about neonatal sepsis. Next slide, please. And then in terms of management, even though we always say blood culture is an absolute must, but sometimes it's difficult to obtain a blood culture. It could be technical. I work in places where I have great nurses that are very good at obtaining blood samples from babies. Well, sometimes they run into trouble. Even the best of them can't get a drop of blood from a baby. So if that's going to be an issue, then it's probably better to err and administer antibiotics anyway. But you should at least endeavor, at least make an attempt to get a blood culture. If that becomes an issue, nobody is able to obtain a blood culture from a baby. For again, babies are small, their veins are very small, and then you should probably go ahead and administer antibiotics anyway. Again, blood culture, attempt it at least. And then in terms of how much else to do, your blood counts are helpful, and also markers of inflammation that we'll go into in subsequent slides maybe good things to obtain to aid in deciding how much to do and whether to administer antibiotics or not. But clearly, if there is any concern, I think it's better to err on the side of caution, administer antibiotics first, and then think of what might be the better course of action later. So again, antibiotics administration intravenous is the way to go. Right, even if you have to place umbilical line in to administer antibiotics, if they are very sick, that's justifiable, I think. But if you've tried and tried and nobody can get an IV in a baby, then administer your antibiotics intramuscularly will be another option. But it's a poor option compared with intravenous antibiotic administration. So typically, again, for early onset sepsis, most of the pathogens you encounter are going to be sensitive to ampicillin and gentamicin or another aminoglycoside of your choice. Typically, we go with ampicillin and gentamicin for early onset sepsis. So if there is a remote concern for infection or for meningitis, then you might consider cephalosporin. But meningitis is not very, very common in straightforward early onset sepsis. It's much more common in late onset sepsis. So typically, your ampicillin and gentamicin will cover the whole gamut of pathogens that you encounter commonly in early onset sepsis. Next slide, please. So we went through some of this already, that in terms of your investigation, blood culture is a must. Blood counts are helpful. Inflammatory markers are good. People use CRP or procalcitonin, whichever is available to you. Urine culture, you should consider it. Think about it. CSF culture, you should also consider it. And the chest X-ray if baby has respiratory symptoms. So in terms of early onset sepsis, the inflammatory markers are not particularly helpful. They have very low positive predictive accuracy, but their negative predictive accuracy is very high. Same thing with your blood counts. A normal blood count should not reassure you that the baby doesn't have sepsis. Whereas if you have a very, very ugly blood count, like severe neutropenia, for instance, that's very consistent with sepsis. Early onset sepsis, again, like I said, meningitis is fairly uncommon. So if a baby, especially if you think a baby will not be able to tolerate an LP, then you could wait on the CSF studies. Chest X-ray is optional. If a baby has respiratory symptoms, yes. Urine culture is tricky. If you obtain a random sample obtained on a cutting material placed on the baby, that's a lot of times you grow pathogens that are difficult to interpret because you don't know what skin flora from colonized skin surface versus a true urinary tract infection pathogen. So, but if you can, and that's what I advocate for my trainees, is they should do a suprapubic tab. If you do a suprapubic tab, you obtain one colony forming unit from a suprapubic tab. Is very credible. On the other hand, from your random sample that you collect with even a catheter sample, it's still, you need more than 100,000 colony forming units for you to take any pathogen seriously. And you have to have a bunch of white blood cells. That's, to me, urine is good for the urine analysis, for instance. If you have leukocyte esterase, you have nitrite, you have lots of white blood cells in your urine. That's concerning, very concerning, almost confirmatory for urinary tract infection. So that's, for me, the utility of urine is for the urine analysis more than the culture itself, especially if it's not a suprapubic tab. Next slide, please. So we talked about blood culture, the importance and the preeminence of blood culture. We've said that multiple times already. Ideally, if you can obtain at least 1 ml of blood, as much as you can, but at least 1 ml of blood, you increase your yield from your blood culture tremendously. And again, urine culture is more relevant when you are dealing with late onset sepsis. Same with cerebrospinal fluid analysis and culture. Those are again more relevant in late onset sepsis. But anytime you have a positive culture, early onset, late onset, then it behooves you to obtain cerebrospinal fluid for culture because easily 20% of babies that have sepsis, that have meningitis, may have a negative culture. So, but anytime you have a positive blood culture, you need to go back and obtain a spinal tap right away before, even though you could argue that baby is partially treated, but again, if cell count is abnormal or the glucose and protein in the CSF, then it's still useful. It's still a useful addition to your investigation. And the fortunate thing is that the turnaround time for your blood for cultures has improved significantly because now a lot of places use PCR and other novel new techniques to detect pathogens in the blood, in your urine or CSF, that the turnaround time is now in a matter of 12 hours, you could have your result. And that's why we actually narrowed the rule out sepsis antibiotics, the empiric antibiotics we administer for rule out sepsis to 36 hours. And we are actually moving towards 24 hours because your culture or your blood is still negative by 36 hours, it's unlikely to grow anything beyond that. So most places are now adopting 36 hours, and we are actually trending towards 24 hours of rule out sepsis. Next slide, please. So again, we've talked about all this actually about the LP and urine culture as well as the biomarkers, those inflammatory markers, CRP. Um, they are not particularly sensitive, as I said, and also their positive predictive accuracy is very poor. On the other hand, they have very, very high negative predictive accuracy. So, for instance, you obtain CRP and it's normal, within normal range, the likelihood of infection is very low. But more importantly, those markers are good for trending. So, for instance, you obtain your CRP is 2, and then 24 hours later is now 4 or higher, then that's concerning for infection. You may want to prolong your antibiotics duration based on that alone. On the other hand, if you obtain your CRP and it's within normal range, and then 24, 48 hours later is still within normal range, it makes the likelihood of infection very, very low. That's one that you probably can safely discontinue antibiotics. Another investigation you might consider, again, depending on how sick a baby is, it's blood sugar, again, because sepsis is notorious for causing a hypoglycemia, and then you might think of checking the bilirubin level too in babies that are being considered for early onset sepsis. X-ray, again, depending on your concern for respiratory illness, may be another thing to consider. All right, next slide, please. So, Dr. Mbisaka, oh, I'm butchering your name, Lillian. Mr. Mbishaka is going to take us through another vignette.
All right. Actually, we're going to switch things around a little bit. I'm going to let Dr. White go, and she's going to talk to us about infection prevention. And then I'll wrap it up at the very end. So I'll just skip forward and have Dr. White talk to us about infection prevention and ties it into, just overall, how can we prevent vertigo infection at this point? No, horizontal transmission. Go ahead.
Thank you. Thanks. Yes. I actually will have to run and take care of babies after this. So, This has been an area of interest of mine for many years now. I took this picture in front of a hospital I was working at in Malawi. And as you can see, it says infection prevention is a commitment for all. And it's so true. And some of the things I will talk about, everyone will be aware of, will have heard before. And there are a lot of challenges in really effectively performing infection prevention, but it is such an important topic, especially for the small, vulnerable, and fragile babies we take care of. So, next slide, please. I take photos, infection prevention related, everywhere I go. And so this is a photo somewhere I was working. Again, I think sort of gets to the heart of why infection prevention is so important, because it gets back to safely taking care of babies, not only safely taking care of babies, but also safely protecting ourselves as healthcare providers from some of the things that we may encounter in the practice that we do. Next slide, please. And so there's mention earlier in the talk about healthcare acquired infections. These are also known as nosocomial or hospital infections. And these are infections that occur while babies are receiving our care. They didn't originally come in with an infection. They weren't born with an infection. This is an infection that they acquired later on while they were under our management. And healthcare acquired infections are considered the most frequent adverse event that happens while patients are receiving care. Next slide, please. And this healthcare acquired infections are a problem everywhere. They are a problem here at my hospital in Minnesota. They were a problem in Cincinnati. They are a problem everywhere. No particular place has solved this problem. We know that healthcare acquired infections go both ways. They can happen in patients and they can happen in staff. And there are some factors which increase the risk of these types of infections happening, include anybody undergoing an invasive procedure, such as a surgery, anyone who's severely ill to start with, and more vulnerable. And then certainly we have increased risk of hospital-acquired infections when people don't adhere to prevention practices, including hand hygiene or washing hands. Next slide, please. And again, this is very basic and things that we know. And to me, in the hectic practice of neonatology, from moment to moment, I think sometimes these things are easier to forget or to put to the back of my mind. But we know germs are everywhere. We know that the things that we do when we take care of babies can put the babies at risk of infection. And we know that the work we do prevents many opportunities for germs to spread. Next slide, please. And so in babies, there are special considerations for healthcare-associated infections. These types of infections in neonates are associated with increased mortality, increased hospital length of stay, increased healthcare costs, and increased risk of neurodevelopmental disabilities among those babies who survive. Next slide, please. And so some studies that are out there show that, data that was collected back in the early 2000s at a Kenyan hospital between 2000 and 2009 were studying their rates of nosocomial infections, specifically bacteremia. And they found that for those patients who acquired a hospital infection, their mortality was double that for a patient who came in with a community-acquired infection. Next slide, please. And so one of the most powerful and effective things that we can do is wash our hands routinely. Hands are the most common transmission mode of pathogens in healthcare settings, and germs get passed either from person to person. For example, if I don't wash my hands and I go in to examine a baby, and I start to palpate the baby's abdomen with my dirty hands, I may have transmitted germs that way. Germs can also be transmitted indirectly. So there are bacteria, other pathogens that will live on surfaces, on linens, on bed rails, on computer keyboards. Cell phones are notorious for being incredibly dirty. And so again, if we don't wash our hands after handling something such as our cell phone, we could be passing along germs to our patients. Next slide, please. And so sometimes I get questions about which is better, washing hands actually with soap and water, or using hand rub or alcohol-based sort of hand sanitizer. Either really are equally effective and appropriate. It's important, of course, to wash hands anytime they're visibly soiled, get blood or other body fluids. Any patients who have diarrheal illnesses, it's important to actually use soap and water, but otherwise either is equally as effective. Next slide, please. And so there are five, what the World Health Organization calls 5 moments that we should be performing hand hygiene. Anytime before we go start our patient contact, before any type of clean or aseptic procedure, after a body fluid exposure, after touching a patient, or after touching patient surroundings. So leaving a patient's environment, we should be cleaning our hands before we go to the next patient's environment. Next slide, please. All right, gloves are another topic that come up. So gloves are really important in preventing hand contamination. Gloves are a great physical barrier to transmission. But gloves do not prevent the need for hand hygiene. So gloves are not 100% impermeable. There are bacteria and other pathogens that can move through gloves. And so it's important to clean hands before putting on gloves as well as after removing gloves. It's important to wear gloves, of course, anytime working with body fluids, anytime working with wounds or other non-intact skin, or contacting potentially infectious material. Next slide, please. All right, and when to change gloves. So there are a number of scenarios that are mentioned here. So when you finish care for one patient, you're moving to care for another patient, it's important to change gloves. Anytime your gloves are torn. I'm going to mention cell phones again. So I see, as healthcare providers, many of us are so busy all of the time, and we're in the midst of doing patient care. We've cleaned our hands and we've put on gloves. We're getting ready to assess a patient, and then the phone rings. And sometimes when my phone rings when I'm working, it's important. It's another consultant or someone else who I need to talk to that's relevant to the work that I'm doing. And so I see many people answer their phones with gloves on, then hang up the phone, put the phone down, and go on to assess the patient without changing the gloves or washing hands in between. And what is really the appropriate way to do that, and the safest way, is to take off gloves, answer the phone. After you're done with the phone, clean hands, put on a new clean pair of gloves. Next slide, please. And then I will talk a little bit also about the disinfection of medical equipment, an area that I've done some research on. As Dr. Lillian mentioned at the very beginning of the talk, this is an important way that pathogens can move between patients as well is infected medical equipment. There are old case reports about outbreaks of pathogens in neonatal units that, on investigation, actually were linked back to contaminated suction units, contaminated bag valve mask, supplies that were used to resuscitate babies. And so we know that the equipment we use to care for babies can, in fact, transmit pathogens that will make babies sick. And so when we talk about disinfection, there's a lot of terminology that gets used interchangeably, but these terms really do mean some different things. And so when we talk about cleaning, cleaning is the first step in a disinfection and sterilization procedure. And cleaning really refers to the physical removal of foreign materials. Cleaning, for example, with soap and water, doesn't kill organisms, but it physically removes them. It washes them away. In the picture I show here of this suction unit, you can see at the very end of the tip there that there's still a bit of material there. Yes, that wasn't physically removed. And if there's material like that that's left on there when it goes forward for disinfection or sterilization, that material can make the disinfection or sterilization process less effective. And so cleaning is the first step. If there's blood or meconium, mucus on the equipment that we're using, the first step is cleaning to physically get rid of any of that foreign material that we can see. Next step, please. And so there is criteria actually that tells us, sort of guides us about how we should be thinking about disinfecting equipment. And there are different standards based on the type of equipment that we're talking about. And so the Spalding criteria was developed by a man by the name of Dr. Earl Spalding way back in the 1960s. And he came up with a classification system for equipment that helps us to say, does this equipment need to be sterilized? Do we wipe this equipment down with alcohol? Can we put it in a bucket of chlorine? And so the classifications of equipment, critical would be that equipment that enters into sterile tissue. So it's a lot of our surgical equipment. And at minimum, critical equipment needs to undergo sterilization, the most rigorous process of disinfection, in order to safely be reused between patients. And then we have semi-critical equipment. And so that's equipment that doesn't enter sterile tissue, but can come in contact with sort of high-risk tissue for transmitting infections. Those are things like the mucous membranes, the nose and the mouth. And so that's a lot of our respiratory equipment. And for that type of equipment, the minimum level of disinfection that it needs to undergo is something called high-level disinfection. And when possible, sterilization is really preferred, but high-level disinfection is also very adequate for this type of equipment. Now, the difference between sterilization and high-level disinfection is that sterilization will clear equipment of all pathogens, including things like bacterial spores. High-level disinfection will clear all active pathogens. There are things like some bacterial spores that could remain. And so that's the difference between those two types of disinfection. Finally, we get to the non-critical equipment. These are things like our stethoscope, pulse oximeters. And so this type of equipment only comes in contact with intact skin or doesn't touch skin at all. And so something like low-level disinfection is adequate for this type of equipment. Next slide, please. So something that's really important to sort of be mindful of and think about is what type of equipment we actually have. I've worked in places in Kenya and Malawi and Nigeria and some other neonatal units where, I really see a mix of the equipment that's present there. The circular mask that you see on the screen, that mask is designed to be reused. It's designed to be disinfected. That mask is made by a company called Laerdal, and can undergo sterilization. That mask can be autoclaved. The other one present on the screen is a single-use mask, and single-use equipment is really challenging to disinfect because there aren't any guidelines for how to disinfect it. It's meant to be used once and thrown away, and there are many places where that equipment is too needed, too important to throw away between every individual patient, and so it gets reused. And what is the best way to clean that equipment? There still aren't great answers about that, but I'll talk a little bit about some of the work that I did. Next slide, please. Just to finish up a bit with our terminology. So we talked about cleaning as physical removal of materials, of pathogens, and then disinfection is actually the killing or the inactivation of the pathogens. And disinfection often involves chemicals such as chlorine, could be alcohol, could be hydrogen peroxide, heat. So boiling, steaming equipment is a way to disinfect it. Autoclave works by a heat method, and then UV light can also be used for disinfection. Next slide, please. And so this is a guideline that came out back, oh gosh, probably 15-ish years ago now. And it came out by an organization called PATH. And they, as you can see there, they are reprocessing or disinfection guidelines for basic neonatal resuscitation equipment. And the guideline was developed based on gold standards of disinfection and sterilization, and then was sort of adapted with input about how to really achieve those gold standards in low middle income countries. And so the guideline you can see there has multiple different stages. There are 4 stages. In the first one, it's preparation. It's preparing all of your materials. It's acquiring the proper PPE for the person who will be doing the sterilization. Again, wanting to protect our own staff from any pathogens that are there. The second stage is called pre-disinfection, also known as the cleaning stage. So that is when you can see they're physically wiping down the outside of the equipment. They disassemble it and scrub it with some soap and water. And again, they're trying to get rid of the blood and the meconium. And even if you can't see any of those things on the equipment, the first step needs to be cleaning it. To remove anything exterior that will interfere with the disinfection. So the next step, we get to disinfection. There are several options for how to disinfect the equipment. So one is sterilization, if that is an option at your facility. And you have equipment that will tolerate sterilization. The single-use equipment will not tolerate the autoclave. It will melt in there. Other options there for disinfection include either boiling the equipment in a pot of boiling water or steaming it. So boiling water and then placing a pan of some or a strainer of some kind on top and putting your dirty equipment there so that the steam is able to disinfect the equipment. These methods also the single-use equipment will not tolerate. There was interest at a hospital I was working at in Kenya to steam equipment. And so we worked with them to implement a steaming process. And then we melted 2 of their single-use masks and we promptly stopped steaming equipment because clearly that was not going to be an appropriate solution there because we couldn't be melting the important equipment that was being used there to help resuscitate babies. And so the last option given there is using chemicals and achieving high-level disinfection by chemicals. And so the two chemicals that are mentioned in this guideline are chlorine, 0.5%, and with the chlorine method, you place equipment into a bucket of the proper concentration. The equipment must be fully submerged to be disinfected. I've been some places where there are nasal cannulas and there's tubing and all kind of things overflowing from these buckets. And any equipment that is not submerged there in the solution is not being disinfected. And so with the chlorine, the equipment gets submerged in the bucket, put a lid on so it gets protected from any other pathogens or things that might fall in there. And then it dwells for 20 minutes. The other chemical that's mentioned is activated glutaraldehyde, and that is not one I've seen used as much. It's a bit more of a volatile chemical, but there are certainly other options for chemicals. I mentioned some things like hydrogen peroxide and others that could potentially be applied here in this category as well, that just weren't explicitly identified here. So after the disinfection, the last stage in this guideline is post-disinfection, and that's where after the equipment has been disinfected, you want to look at it. Make sure that it looks like it has come through your disinfection process without incurring any damage. Want to reassemble the equipment, make sure that it works, that it gets properly reassembled, and then that equipment gets stored in a clean and dry place. Next slide, please. And so this is just one image of a disinfection reprocessing room I helped to set up in Kenya. And so straight ahead there, you can see a red sign on the wall that says dirty. In the sink, that is where the used equipment would come from the unit that needed to be disinfected. And so the equipment then would move from left to right around the counter. You can see on the right-hand side of the image up on the wall a green sign that says clean. So the equipment always needs to move from the dirty area to the clean area and not mixing up equipment back and forth to contaminate it between the two. And so we set up the various steps there. We did a pre-disinfection. You can see the little container with the bright yellow or green lid. We wiped down the equipment at our pre-disinfection. We scrubbed it with soap and water in the sink. We then put the equipment in the pot to steam it. And then from there, it moved to the metal bucket at the far right of the image was to receive the disinfected equipment. And from there, it went back into storage. So, next slide, please. So this is from an article that came out fairly recently. I think I don't have the date on here. But it's all about infection prevention in the neonatal care unit. And on this particular table names a number of those different compounds, chemicals that can be used for cleaning and disinfection, and the different ways specifically that it's appropriate to use those chemicals. So I've highlighted a couple that I have seen used more routinely, those being alcohol and bleach. Next slide, please. And so infection prevention is a huge topic. There's a lot to talk about. There's a lot to cover. It really helps in thinking about infection prevention to involve a lot of the different players in a facility and to form an infection prevention team. There are changes that need to happen at all kinds of levels. System changes, making sure the right supplies, making sure the right chemicals, materials are available for disinfection, making sure soap is available. Alcohol hand rub is available for providers to clean their hands. Reminding people, again, we still have healthcare acquired infections in our unit here. We're constantly reminding people. And so infection prevention is really a team effort. Next slide, please. These are just some resources for infection prevention, again, from the World Health Organization. I think these slides will be available to you if any of that would be helpful. So that's all I have for you this morning. Thank you again for having me.
Thank you very much, Dr. Annie White. Dr. Msamichak, I know you're going to come and finish up, but I have a couple of 3 questions, which if it's okay with you, I can ask them, then you see if you can answer on your presentation.
Sure.
Okay, so I have a question from Dr. I'm sorry if I'm misspelling your name. I am Kalinjonji from Intermediate Hospital, Oshakati region in Namibia. And he's saying, in a discussion, can you answer brief approach on the management of neonatal septic shock in the part of the use of inotrope support? That's one of the questions. Let me see, from David Mhagama from Tanzania. He's asking, so I had my stuff and I moved away. Oh, he's asking, what is the reason for evaluating lumbar puncture with CSF analysis and culture to an infant with positive culture? And then there's another question that she can answer later when you finish your presentation. So those 2, if is part of your presentation, or Dr. Kimbi can jump in and answer that when you finish.
Yeah, I can answer those 2 questions.
Oh, okay.
Well, I think Dr. Kalengunji asked if the use of inotropes in babies with septic shock. That's again, that becomes necessary if a baby hasn't responded to volume is your first go-to. You give them a bolus of, like the baby I presented, we actually had to give the baby a couple of boluses of normal saline, and we ultimately had to start the baby on inotrope because wasn't maintaining his blood pressure, urine output had dropped off completely, and clearly the baby was in some kind of shock. Of course, if the baby doesn't respond to volume, then you go to inotrope. Now, the choice of inotrope is all over the place. We use epi, for instance, typically is our go-to inotrope. And sometimes some babies might not even respond to epinephrine on top of the fluid boluses. And then those ones we will put on corticosteroid as well, hydrocortisone. So they may even require support beyond the inotrope. And then the second question was in regards to CSF analysis. After a baby has returned a positive blood culture, the benefit, at least the way the concept is that if you have meningitis, your duration of antibody is going to be longer. Typically, for your garden variety routine, there's nothing routine about bacterial sepsis. But if you just in the blood, you have bacteremia, typically you go up to 10 days, excuse me, of antibiotic therapy. If you have in addition meningitis or anything to suggest meningitis, either your cell count, your protein, glucose, and culture, then you want to extend the duration of your antibiotic to at least 2 weeks, preferably even 3 weeks. So that's the benefit of obtaining that CSF study after you've returned a positive blood culture.
Is there any question for Dr. Ann?
There was a person called Joyce Gimonge, and she wanted to ask the question, but she didn't type the question. She just wanted to raise her hand, but she was not able to.
You can ask her to unmute. She's still muted. I can see her. She's still muted. Maybe now she's unmuted.
Okay, thank you for the informative talk. I'm Dr. Joyce from Tanzania. It was a wonderful talk, so I have some questions regarding the prevention challenges of neonatal sepsis in the lower middle income country. specifically in Tanzania. So concerning the inadequate infection prevention control, limited access to clean delivery environments and gaps in maternal screening. So what are the key barriers to prevent neonatal sepsis in this setting? And what are the practical interventions would you recommend to overcome them at the facility and community level? Because in Tanzania, our guideline, we are updating our national neonatal guideline. So for premature babies, especially below 1 kg, before we usually used to give them antibiotics, but for now, it's better we not giving antibiotics based from the clinical background. So what is your experience and what are you recommending from the IPC, from prevention control and on the concept of premature babies? And another question, considering the limitation in laboratory capacity and lack of rapid diagnostic tool, especially in Tanzania, and the non-specific clinical signs in neonates. So what do you see as the most feasible and effective strategy to improve early and accurate diagnosis of neonatal sepsis in lower middle income country like yours, and experience, and how can we better balance clinical decision making with the risk of antibiotic overuse in this setting? Because some studies have shown that most neonates, they're being given antibiotics, but when you come into the clinical background and the investigation, sometimes investigation, they are usual normal results, and the clinical background they are normal, but these neonates are usually given antibiotics in considering of antimicrobial resistance strategies. Thank you so much for the nice presentation.
Dr. Ann, you want to address the infection prevention component?
Sure. Yes, yeah, absolutely. Excellent questions. So in your question, I think some of the challenges that you mentioned specifically in Tanzania, in some of the community centers, the environment itself, not always being particularly clean. And absolutely that increases risk of infection for neonates, especially the preterm. There are lots of guidelines about cleaning and disinfecting incubators that the preterm babies reside in. There are recommendations about cleaning things we called high-touch surfaces routinely. Those would be things like the doors to the incubators, like doorknobs, like computer keyboards, like monitors, our cell phones. A lot of those guidelines will be in the World Health Organization sort of references that I put up there. They're in general high touch surfaces. So you imagine anything we're touching a lot. That would include things like our cell phones. Should be wiped down with alcohol or a chlorine solution at least once every day. And so the incubators, the outside of the incubators should be getting wiped down. The monitors should be getting wiped down. Those are all things that will help to decrease transmission of infection. It's really helpful to have dedicated environmental cleaning staff. I know that some of these disinfection IPC responsibilities fall to providers in some places, and people are already so busy with patient care that sometimes the IPC tasks don't get done in a timely manner. And that's just because the priority, of course, is managing patients and taking care of patients. So having dedicated staff is helpful. Having, the materials that you need, alcohol or chlorine, and routinely having a schedule for routinely cleaning and disinfecting those surfaces, routinely changing the linens that the babies are laying in. All of those things will help prevent infection.
Did that answer your question, Joyce, on the IPC part?
Yes.
Yeah. So Dr. White has to get off to go and do clinical work. I just want to say she's more African than most of us. She's been to Malawi, Kenya, Nigeria a lot, Burundi, Guinea. She's been all over Africa to do her work. So thank
except
you very much, Dr. White.
except Tanzania. So she needs to come to Tanzania.
I'd love to, yes. Yes, and I would be happy. My email is freely available. You can include. I'm happy to answer any more questions that people have. Unfortunately, I just do need to go this morning. So thank you all again for having me.
Thank you very much,
Thank
Dr.
you.
Annie.
Bye, Ann.
I think the second
Thank you.
part of the question was, Joyce, I forget the second part of the question, had to
How
do
do you
with
balance
antibiotics.
antibiotic stewardship with and not missing cases and you you can take it on, Lillian. Go ahead.
Oh, you go ahead. I was just getting you to this point here where you were kind of offering like some of the tools that could be utilized.
Yeah. So again, that's a good question. And the good thing is where you do your blood culture, the turnaround time is so fast that you don't have to leave babies on antibiotics for longer than 48 hours. Definitely for longer than 32 hours, definitely no longer than 48 hours. So that's one way to minimize antibiotic exposure or overuse. Um, in cases where you are not completely convinced that the baby might be infected and you have time to observe a baby, that's one time that you could use clinical discretion and say, look, I'm not sure if this baby is infected or this baby is struggling with transition and I can afford to observe. Especially if the baby is not good. I have that luxury. My babies are in the NICU. I have time to observe them. If you are encountering them in an outpatient setting, it's probably different. But if you have time to observe and if you're not completely certain that the baby is infected, that might be the better part of discretion. But again, yeah, antibiotic stewardship is a big concern everywhere, and anything we can do to minimize them without taking undue chances on babies, and then that's what we need to keep doing. I know
Yeah.
that's a lot of hand waving. It doesn't particularly answer your question, but that's the best I can do. Again, once you have a positive culture, if you know the organism, you can then narrow the spectrum of your antibodies as quickly as possible. For instance, group B strep. 100% of isolates in the United States are sensitive to penicillin. So there's no reason to leave them on ampicillin and gentamicin beyond the time you have your culture back and it's group B strep, you just narrow it down to penicillin right away. So those are little things that we could do in terms of antibiotic stewardship.
Yeah. And speaking as somebody that does not do the NICU, I take care of like a newborn nursery. Like for us, risk factor stratification is very important. And those are some of the things that I think we talked about. And we use this calculator a lot and say, okay, what is the, what's the gestational age for this baby? What did mom have a fever? How long were the membranes ruptured for? I know in Tanzania it's not routinely screened for GBS, but of Group B strep. But if you happen to be working in an area where that is available, then you do it. But if they're under 36 weeks, when baby was born, you might not have that information, and so your status is unknown and whether they got antibiotics. And this calculator will tell you whether, if they're well appearing, like just observe them, do nothing, just clinically monitor them every, 4 hours. And this is a baby that you will probably not discharge at, 12 hours or 24 hours. This is a baby that you might want to observe longer, keep them in the hospital longer for observation, maybe 36, 48 hours, because if they're going to declare themselves as, the transition period should be close to like, being done at that time from a in hospital stay standpoint, and you can feel reassured and have close follow-up outpatient. And then you have the babies that turn out to be in the middle, where it's like, they're not quite well appearing, they're not quite critical that they need to go to the NICU. Those are the babies that you might, observe and say, right now we don't need to start antibiotics, but we need to send a blood culture. And I know sometimes, like, there's some places, like in Tanzania, where blood culture might take 7 days for you to get it back. So obviously, it's not going to help you in that instance. But if you have PCR, if you're at a facility that has PCR testing, then you can probably get a presumptive, or it will be negative, and there will be nothing there. So that's a baby that you observe, and if all of a sudden they're hypothermic, they're feeding poorly beyond what would be normal for a newborn. If they are, tachypnic, then at that point, it's like you were in the watch stage and now you've given me these clinical signs. So I think at this point, I'm more worried about infection than just transition. And that's how you can balance that overuse of antibiotics and also, just not missing that critically ill baby that might, rapidly decline on you. And then the third part is like, if you're really concerned enough, but you're not sure, like 48 hours of antibiotics, 36 to 48 hours of antibiotics, you do your workup, you monitor clinically, and then you can decide to like de-escalate and antibiotics at that time. Does that answer your question?
Thank you so much. Thank you for the good answers. And also maybe I pose a challenge, maybe a question, like the use of probiotic supplementation for premature neonates. What do you think the probiotic supplementation for premature neonates as a promising intervention as a prevention of neonatal sepsis? Do you have
Reba,
data? Do you have data or do you have research that is going on? Because
we
as a one of the major risk factor for sepsis, premature is number one. Even the lower the base weight, like below 1 kg, is a risk factor for sepsis. So what is your view regarding the use of probiotic
pre
supplementation?
you talking of pre or probiotics?
Probiotic.
Prebiotic.
I mean probiotic supplementation.
Okay. There are so many studies out there, and you look at meta-analysis from those studies. It looks like probiotics, they are good at not preventing, but reducing the risk of infection. But the studies are all over the place. I mean, we used it in my institution. We were using it until September 2023. The FDA actually came out and said we should stop. Everybody should stop because there's no pharmaceutical grade probiotics in the market. So, and you don't know what you are getting. Some of them have one single bacterium in there. Some of them have multiple. Some of them have 100,000 CFU per mil. Some of them have 1 million CFU. You don't really know what you are giving. The market is a zoo out there. The FDA in the United States actually said we should not be using it until we've had convincing studies, randomized controlled trial. And if you're going to use it, that's the only premise for using it is in a controlled trial. So we stopped using it almost 1.5 years ago now. And we think it's beneficial. We actually thought we saw a difference in our rate of necrotizing enterocolitis in our unit. It went down significantly during the period. Of course, there were other factors as well. But we are forbidden for using it now until there's some clarification and until hopefully we are hoping that there's a pharmaceutical grade product that is being proposed to the FDA. I think they've submitted their data to the FDA. We see what comes out of it. But right now, There are so many attributes to probiotics that we don't know how true some of them are. I know in Europe, they use it a lot. It's just standard of care in Europe. But in the United States, until the FDA put out a statement of caution, it was getting really popular. Maybe two-thirds of NICUs were using it and adopted it at that time. But now we are back to square one. Nobody's using. I mean, if you use it and something happened to a baby, and the reason the FDA came out with the warning was some babies actually died of neonatal sepsis from organisms in the probiotics. Very unusual organisms that are in the, I think it's a bifidobacterium and lactobacillus were recovered from those two babies that died of sepsis. Same, and the genotype, the isolates, they match 100% with what was in the probiotics. So it's not without its risk. But overall, that's my opinion, of course, that the benefits outweigh the risk. But for now, at least in the US, there's an embargo, or so to say, that we shouldn't be using it unless it's in a research setting. We are hoping that the product will be in the market within the next 6 months that will meet the criteria to satisfy the FDA to be licensed as a pharmaceutical grade probiotics. So.
Thank you, Dr. Kinby.
Sure.
I think my portion will have to find another time to wrap it up. I think I would rather, it's like I want to respect people's time. It's 8:23. We can take some questions and then we'll find a time to just tie it all together on the treatment. Now we know how to, we know the importance of early diagnosis. We know the importance of treatment. We know the importance of infection prevention. What we were going to do with my talk is just tie it all together and talk about, the algorithm for management and treatment. But I think in the interest of time, Dr. Gabon will have to find a time where we can do another talk. And I want people, if people have questions, I want to give that like the next probably like few remaining minutes to answer a few more questions.
Okay, so I
these
have
are important questions.
I have a comment from Ms. Victoria Jones, who has been in Tanzania so many times as a global volunteer. She said, although I'm no longer in healthcare, but in hands-on in the classroom as an educator, this guidance of disinfections covers a wide genre of profession, especially working in a classroom full of small children, pre-K, 3 to 5 years old, specifically as it refers to the toys, books, and walls. So she's talking about cleaning all those environments. Also prevention of infection, we work for those young people, yeah.
Absolutely.
Mm-hmm.
And these young people are the ones that are, helping pass on those germs to their siblings once they get home.
Exactly. And I think
so hand hygiene.
Yes, definitely. I want to add more comment to Dr. Annie White, and that was she was responding to Ms. Joyce Gimonge on environment. How can we include environment in prevention of those infections for these newborn or neonates? So one of the things that she said, they add individual staff who specifically cleaning the equipment. Definitely asking healthcare workers to do that is not fair because they have a number of children. One of those hospitals that we've visited during our medical mission, one nurse has more than 5, 10, 15, 20 babies. There is no way she or he is going to have a time to clean up those bassinet or where the baby is sleeping, the equipment, so where they're beeping up and down. I think even including the moms who are coming to feed those babies, they need to also be watchful, wash their hands, keep their hands clean because these babies are already vulnerable. So that's another one way of also preventing infection by including also the healthcare workers, definitely, also the parents, definitely, and also having individual staff specifically doing like almost routinely. I know she was suggesting every 24 hours, but I think because of so many touching and stuff, these babies needs requirement from healthcare workers. So they do need cleaning a little bit more. If it was every shift, that would have been better because people don't use gloves between babies, unfortunately. We know lack of resources. We understand that part. But still, if everybody can do a little bit at a time and clean up and be aware of their hands, what is touching, and before one baby to the next, definitely wash your hands in between. That will definitely reduce a significant of those chances and also help these babies so they don't get sick.
Yeah, thanks, Dr. Gabon. Yeah, like soap and water are like one of the cheapest interventions that we have. And as long as just have available, easy access to soap and water and just washing hands in between cares, that can like reduce infection by a tremendous amount, whether it's starting from the delivery room to the newborn nursery to the NICU to like the post-surgical moms, like it just spans everywhere. Like hand hygiene can we can prevent a whole lot of things before we even move on to the fancy stuff. Any other questions before we?
I think these are the ones that I have from the chat. Unless people who are still here have any questions. Yeah, I think that's all the questions I have.
All right.
Yeah, so we are grateful. There was a lot of people from Tanzania, different hospitals, people from Namibia, that's great. People from US here, that's even better. So thank you very much, everybody, for attending and listening to our esteemed facilitators here. So definitely we're gonna have session
Part
2
two.
for the neonatal sepsis. And also once everybody who attended the training, we will send the recording, and I know 3 people ask you for their slides. Yes, and then also we will share the PDF slides and then encourage you guys to send those questions so we can share with the facilitators. And if those questions can be added to the next presentation, that would be great. So we usually have, like, if we have this now, we give the presenters time to be able to figure out their availability. And then it might be in end of July or early August, we can have another session. So then at least that we have time to come back and answer the question. And also that also give you the chance to review the video and then plan your questions, send the question ahead of time so they have the chance to include it in their PowerPoint. That would be great. And then, or even you can come in yourself and then be able to ask those questions. So we'll be happy to have you guys. So on behalf of QHSC, thank you, Dr. Akimbi. Thank you, Dr. Msambichaka. Thank you, Dr. Annie White. We are blessed to have you guys here to share this knowledge and be able to inform each other, learn with our colleagues all over the world to be able to save these babies one life at a time. So if everybody does their work, save at least one baby, will be a better place, definitely. Dr. Msambichaka,
Thank you.
Dr. Kimbi.
Have a good day. Yes, thank you very much. Good day to
Thank
everybody.
you.
Yeah.
Thank you. Thank you very much. Yes.
Bye-bye.
Bye.